So we're just gonna finish up abdominal. So we're gonna discuss three potential pathologies or conditions that you could potentially encounter when we're scanning pediatric patients. So common surgical conditions. So pediatric patients may appear again in our ultrasound lab on an emergent basis for extreme abdominal pain, vomiting. Um, so usually, kids feel sick, they're having belly pains, abdominal pains, they're nauseous, they're vomiting, they might have fever, loss of appetite. And then the three most common, surgical conditions or reasons why they could be there, or possible things that could be occurring, or again, acute appendicitis, intussusception, and we're talking about infants, hypertrophic pyloric stenosis. So appendicitis. So this is the most common cause of emergent surgical abdominal pain. So again, we talked about gastroenteritis being the most common cause of, abdominal pain in pediatric patients, but the most common surgical cause of abdominal pain in pediatrics is acute appendicitis. Typical age ranges now when we're talking about appendicitis, it's usually in that early childhood range. So, older than toddlers. So you're thinking 5, 6, 7 years old, all the way up to like early adolescence. Um, can occur in children very, very young. And it can also occur in older children as well. It can occur in adults. So again, don't just let, range, say like, oh, no, it's definitely going to be negative. Because, acute appendicitis can happen pretty much at any age. Um, though it's very rare, again, in very young children, and it has a male prevalence. So it's almost about a 2 to 1. It's more common in males than females. Um, so when we're thinking about appendicitis, we have to think of what the actual, appendix is. So basically, it's I want to say it's an extension of bowel, so it's an extension of the large intestine, and it's basically just kind of like think of it like a sock or a tube that's hanging off the base of the appendix. And fecal matter, fecal material, can get passes in and out of the appendix. When you're scanning it, you can actually sometimes even see fecal material enter in and enter out, particularly, if they have a lot of fluid within their bowel, if they have diarrhea, you can see it kind of come in and kind of come out. So things should be able to move freely in and out of the appendix. When problems occur, when issues occur, and appendicitis develops is when that appendix becomes blocked or lodged. So fecal material gets stuck in there, gets lodged in there, and then subsequently causes an infection within the appendix. We'll see in a moment some of that fecal material, when it gets lodged, stuck in there, it can actually harden, calcify, become an appendicolith. So it's basically like a calcified ball of stool in there. They actually will shadow, similar to like a large gallstone. In infants and young children, progression to acute appendicitis can occur quite rapidly. So, sudden onset of pain, the pain gets gradually gets worse and worse and worse. The kid gets sicker and sicker and sicker. And then it could progress to potential rupture. So that's the major complication that we'll worry about, is that, the appendix becomes enlarged, becomes inflamed, and then eventually ruptures. And then, that could lead to a peritonitis, infection. So then even sepsis. So it's a major deal, so we want to get to this patient, treat them, whether that's surgery or antibiotics, and try and, get to them quickly. Because again, that progression can happen quite rapidly, particularly the younger that child is. So the younger the child is, the faster those symptoms will kind of escalate and lead to potential rupture sooner. So typical presentation, we hear about with appendicitis is right lower quadrant pain, vomiting. So other things, that you can look for in addition to that, nausea, loss of appetite is a good one. So when I get a kid in, I'm doing an appendix study, like Are you hungry? Hungry at all? Like, how are you feeling? Like, no, not really hungry. Well, what's your favorite food? If I gave you your favorite food right now, would you eat it? Oh, yeah, yeah, I'd have a slice of pizza or chicken nuggets or something like that. Then that's not really, loss of appetite. Like kids who truly have appendicitis, they feel sick. Like they're just like, they're out of it. They're just not their normal selves. They're lethargic. They don't want to do anything. Um, the other question I like to ask with these studies is, can you point with one finger where your pain is? So if that kid goes, one finger, boom, right there, and they point to one spot, that's a more indicative of someone that's got acute appendicitis versus a kid that's, pointing all over their belly, going like hurts here, hurts here, hurts here. That's probably more gastroenteritis or something else going on. So pain may originate around the umbilicus area and then migrate out towards what's called McBurney's point. Um, it's just showing, where McBurney's point is located. So kind of just right above that iliac crest, the bone, the hip bone there. I'll be honest, when I first started scanning appendixes, I was scanning way too high. They're really down in the pelvis. They can be fairly pretty low. Um, so this, I disagree actually with this slide from the textbook where it says start with a curved transducer suitable for age and body habitus. You're never really going to start with that curved transducer. You're going to want to start again, highest frequency and just kind of work your way down. When you're doing the exam, some considerations too. Full urinary bladders will distend and push things out of the way. So sometimes a full urinary bladder will make your scanning worse. Sometimes it might actually make it better. So, if you're scanning, trying to do an appendix study, you don't visualize anything, you can't having a hard time finding it, but their bladder is, exceedingly full, have them use the bathroom, void, and then come back and try and scan. That might help things. Conversely, if they're really empty, you don't see anything, maybe we try filling the bladder a little bit, seeing, if that allows for visualization. Turning the patient, decubing it a little bit, so you can have the patient go up on their side, kind of angle down. So they can roll up on their side and you can actually push sometimes from the other side to try and support the back, push it forward a little bit. With appendix, it's a lot of pressure. So this exam requires a heavy hand. So you really need to be able to push and exert a lot of pressure on the child. Unfortunately, if they do have appendicitis, it's not going to be comfortable. So gradual graded compression is slowly applied over the area of the appendix in the right flank, right lower quadrant, again, using your high frequency linear transducer. If you're lucky, you can visualize the appendix kind of draped over the iliac vessels, so it can be seen anterior and medial to the psoas muscle and then lateral to the iliac vessels. Again, like I was saying, when we're scanning the patients, ask the patient to point with one finger to where they're experiencing most of their pain. You could try and isolate and locate the ascending colon, the cecum, so the beginning portion of your ascending colon, and try and see if you can visualize it coming off the cecum. So you can try and see the ileocecal junction. So you can try and visualize maybe the terminal ileum, so the end of the small intestine as it enters into the cecum, the large intestine. Usually, if you can identify, try and visualize the TI, the terminal ileum, the appendix is usually in that area or coming off that area. And just remember the appendix, you can differentiate it from small bowel in that the appendix is not going to peristalse. So there's going to be no peristalsis, no bowel movement with the appendix. You can see, like I was saying, you can start to see things coming in and out of it, but it doesn't peristalse like the small bowel does. I like to kind of do kind of like a sagittal oblique, like when I'm down in that right lower quadrant. So I'm not like totally sag, I'm not like totally trans. I'm kind of like this, like halfway in between as I'm scanning through, the right lower quadrant of that patient. Um, and I'm looking for like a target or a bullseye sign to try and locate what I potentially could think or what could potentially be the appendix. So we're looking for, a very distinctive loop of bowel or has a very distinctive appearance. And then we're going to follow it to see if that terminates in a blind end and try and connect it back to the cecum. In terms of, making that diagnosis of appendicitis, you need to be able to see the entire thing. So you have to visualize, from origin all the way out to the distal tip in order to make that definitive diagnosis of positive or negative for acute appendicitis. Because, I've had patients or I've had cases where I could see just the distal end and I can't trace it back to the cecum, or vice versa. I can see the proximal portion, where it comes off the cecum, get pretty far out, but I can't get all the way out to the distal end. Maybe it just dives deep and, I can't image or see it. It dips behind the cecum, or, for whatever reason, you just can't find the distal end. If you can't prove it comes to a blind end, you can't equivocally say that is the appendix. And there are many instances where just the tip of the appendix becomes infected. So they could have, tip appendicitis. And if you don't see it, it could be potentially positive. So non-visualization, of the appendix doesn't mean that it's a negative study as well. So it may occur for multiple reasons. There might be lots of gas. It might be retrocecal, actually behind the cecum. So it comes off and loops then posterior to the cecum. So those, again, very challenging and difficult to image. I always like to tell, when I'm doing an appendix study, because you're not always going to find it. When you have the patient in the room and the mother or parent is, nervous, and they're worried about this, you just tell them, it's kind of almost like finding a needle in the haystack. We're talking about something that's positive when it's inflamed 6 millimeters in diameter. So, we're talking less than a centimeter or less than half a centimeter or half a centimeter in diameter if it's infected. And it's much smaller than that if it's normal. And we're looking for that all, within that of all your loops of bowel there. So it's challenging. So again, not visualizing independence could be due to several factors that we mentioned: the overlying bowel gas, having a retrocecal position or a deep pelvic position, over or under distension of the bladder, and then lack of sonographer experience. It does take some practice to get good at finding appendixes. Again, during your exam, try changing the patient's position, emptying or filling the bladder, like we were saying. This may help in visualization of the appendix. Bimanual compression. So, like I was saying, you could push from posterior as you're scanning from the front to see if that can help make the appendix visualized. So, like I was saying, the appendix will not peristalse. So that allows you to differentiate it from small bowel, which has a similar appearance. The walls are smooth, so they have nice smooth walls, whereas the small bowel looks more undulated, so it's got more. It doesn't have the nice smooth walls as the appendix does. Appendixes, you're going to see if you start scanning them a lot, every patient's appendix is completely different. Some appendixes are long and thin. Some are more short and kind of more blunt. Some are very tortuous. There are appendix that do curly cues and twists and turns. So they look like a little pig's tail. Some I've seen all the way up, almost touching the liver, all the way down to the pelvis. Encountered appendicitis on like a transvaginal exam. So again, they could be all over. The walls are, again, normal appendix, the walls are not thickened. There's a maximum mural thickness, should be less than 1.7 millimeters. A normal appendix, you should also be able to compress down. That's easier said than done. So me and some of my colleagues in techs and some of the radiologists back in New York, we debated this whole compressibility business. There were some radiologists that wanted to see you be able to actually compress the appendix down like we would a vein, you know. If it's gas filled, that's going to be kind of hard to do. And the appendix is free moving, it's free flowing. So when you're pushing down, you're not really pushing down against much of anything. So when you push down, you can kind of whoop out of the way. So you're trying to put that pressure, it's just moving out of the way. To be able to compress it can be challenging. So I don't like compressibility to be like, the telltale, like, oh, it's not compressible, so it's got to be positive. If it looks like a normal appendix, then it is a normal appendix, even if compressibility can't be obtained. So it's a good example of appendix that's probably tortuous. So I'm in that kind of like oblique orientation, and I'm picking up two parts of the appendix. So this represents the tip, and then we're getting another little piece of it here. So kind of probably diving down, coming, and then coming back up. So again, normal appendix is going to have nice thin walls. There's going to be a little bit of blood flow in the wall of the appendix, but not the kind of hyperemia that we would see with an acute appendicitis. So now the transverse views of the appendix. So again, you're seeing two segments of the appendix. Probably the more proximal portion near the cecum, then a more distal segment. So again, it's probably tortuous to go down, come back up. But again, you notice the appendix, thin walls. There's no free fluid around it. There's no echogenic fat surrounding it. We don't see any large lymph nodes in the area. Versus an acute appendicitis, where we can see the mural thickening. We see the dilatation of the appendix. This one diving, really deep posteriorly. So it makes the distal end much more difficult to image. This one being non-compressible as well. And a nice transverse view for an acute appendicitis. So again, the measurements we're looking for is greater than 6 millimeters. So we do a transverse measurement. We also like to measure in sagittal as well, find the widest sagittal point too. And do a measurement at that area. We could see again thickening of the mucosal layers. We see some surrounding now echogenic fat surrounding it, so reactive fat. Up here was the terminal ileum. So terminal ileum again has a similar appearance to the appendix, but this will peristalse as it connects into the cecum. And we're going to measure from outer wall to outer wall when we're doing our appendix measurements. So this says greater than 7 centimeters is consistent with acute appendicitis. So this is from the textbook. Christianity uses 6 millimeters. We use 6 millimeters back in New York. So here are just a couple more images. Again, so with acute appendicitis, think of, again, this is an infectious process going on now. So with infectious processes, we expect to see increase in vascularity, blood flow to that area. So the body's trying to heal it, bring white blood cells to that area, fight that infection. So we wind up with hyperemia. So there's increased vascularity surrounding that appendix and the walls. So we put color flow on, we can see that increased vascularity. So this is a nice sagittal for the distal tip of the appendix, measuring then from outer wall to outer wall. Um, and we also look for, like I was saying, other ancillary findings. So we look for evidence of free fluid, peritoneal fluid. Um, it's important to look for free fluid because we also worry about the potential that this appendix is already ruptured. So if you're scanning, looking for the appendix and you see a larger fluid collection that particularly has loculations or septations within it, so it's not, simple free fluid, that's concerning, that for potential that this appendix is ruptured already and we are developing, abscess formation now. So any sort of complex fluid is not a good sign. We also look for enlarged lymph nodes, so enlarged mesenteric lymph nodes. Again, it's an infectious process going on, so the lymph nodes are going to become enlarged and reactive. We can document, so if we see a significant number of enlarged lymph nodes as we're scanning for the appendix, there is a condition called mesenteric adenitis. So that's just basically enlarged mesenteric lymph nodes. And that in and of itself can actually cause abdominal pain. So it may not be necessarily appendicitis, just, multiple large lymph nodes. So if there's a large appendicolith, this is also, a telltale sign that this patient has acute appendicitis. So a large appendicolith in a symptomatic patient, again, can be considered virtually diagnostic. So here we can see that appendicolith. It looks like a gallstone. It'll shadow like a gallstone. So this is almost a centimeter. So that's a big guy. It's pretty big, these appendicoliths. Perforated appendix. So again, that's what we're concerned about, is this appendix rupturing and perforating, and then leaking out that fecal contents or fecal matter into the abdominal cavity. So I always tell the story when I was scanning, like doing some appendixes, and I was trying to get, a nice transverse view of this appendix. And like I kept imaging the appendix, like I could in sagittal, I could see, the tip of the appendix, see the appendix there, and it was thickened. And I kept trying to turn on it and rotate it. No matter how I turned on it, it still looked like that. I still couldn't get it to get truly transverse. So every time I kept turning on it, rotating, I was like, this makes no sense. You know, I kept getting, that same kind of almost like a longitudinal view. I was like, what is going on? And it's because it was actually decompressed. So when it ruptures, it goes from that nice circle, appearance to something that looks like a flat tire almost. Like it wants to elongate, but it doesn't quite. So then that's a sign, that this appendix is probably ruptured. Again, we look for any localized, well-defined right lower quadrant abscess formation, to indicate that this appendix is potentially ruptured. These are just showing some enlarged lymph nodes now. So we got a large mesenteric lymph node there. So these were some nice appendix images that I found online. So we got a nice normal appendix. So we got, smooth, thin walls. We could see that mucosal stripe running down the middle of it, coming to a distal blind end. So this is the distal tip. That's more medial, more central, then out lateral, where it connects back to the cecum. This was a good picture showing the appendix actually coming off the cecum. So what it looks like when we're looking for the base of the large intestine and then the appendix coming off. And we're lucky enough to have it draped over the iliac vessels right there. So that's nice. This was a good example of how you can let free fluid kind of help you. So if you're scanning, you see a little pocket of free fluid, really investigate, look around in there, maybe decume them a little bit. Maybe that appendix will move up into that free fluid area. So there could be something potentially going on there. So you could see a thickened walls of the appendix in there. So it's measured over 6 millimeters. So definitely a positive appendicitis going on right there. You can see the thickening. It's a nice transverse view. Throw some color on there. Show some hypervascularity. Then another view. So this one now, the appendix is the distal tip instead of being more central, more medial. So that's usually how they run. So usually, appendix will come off the cecum and then extend more medial and more down. This one actually comes out more towards the side. So the tip is actually more lateral where it comes off. So it comes off and maybe loops back and goes lateral now. So that distal tip is lateral and the proximal portion is more medial. So it probably loops and comes that way as it comes off. Again, so we look for thickening of the mucosal layers, compressibility, any ancillary findings. So again, appendicitis signs and symptoms, nausea, vomiting, fever. They can potentially have a low-grade fever. Before I get into intussusception. One thing that I got in the habit of doing was, if they had blood work done yet, look at their white blood cell count and see if there are actually signs of an infectious process going on with their white blood cell count. One of the things I looked at was actually the absolute neutrophils. So I would look at the white blood cell count, and then I would look at their neutrophil levels. And for a reason, like I kind of discovered, white blood cells up and their neutrophils are up, which is one of the types of white blood cells, but specifically the neutrophils. It seemed more likely that we could be dealing with a positive appendicitis with those patients. So take a quick look at their white count. So they would have elevated white count, potential fever, loss of appetite, nausea, vomiting, and then the pain, right, the quadrant. So now transitioning into intussusception. So intussusception was one of the ones I always kind of was worried about when I first was starting out. I was like, oh God, how am I gonna scan this? Or I was so worried that I would miss it. But it's one of those things that you're not gonna miss. So when you're scanning through the abdomen and you're doing your exam, they're plain as day. So it's not something that's easy to miss as you scan through. You're scanning through what is that? Because they stand out. Intussusception. These kids, when they come in, the pain that they're experiencing is very sharp abdominal pain, and it tends to come and go in these waves. So when they're having an episode of that abdominal pain, they are through the moon, like they are inconsolable. There's nothing you could do, and it's terrifying to parents and these kids, because the kids just they lose their minds. Additional, signs and symptoms, they have bloody stools or dark, tarry, bloody stools because of that obstruction, the bowel obstruction. So basically what intussusception is, the way a radiologist kind of explained to me, it's a telescoping of the bowel. Kind of envision like you've taken like a tube sock and you grab one end of the tube sock and you kind of just push it in forward into the rest of the sock and kind of just make like or like the old fashioned telescopes, like in the pirate. So like when it's out, kind of push it back in, and that's what's happening to the bowel. So it's just like a more proximal segment of the bowel is pushing forward into a more distal segment and creates that. Um, so the vast majority of intussusceptions involved uh, the terminal ileum and the cecum, so in the ileocecal junction, where we look where we primarily look for these intussusceptions. With that being said, they can occur anywhere along the path of the large intestine. So, you can start right lower quadrant, look for terminal ileum and cecum, the ileocecal junction, and work your way up, and then across and down. So basically the protocol, when you're scanning, intussusception, stuff. I'm terrible drawing today. Yeah, that right lower quadrant is kind of like where a lot of the action happens. So we're looking for the terminal ileum, the end of the small intestine where it connects into the beginning of the large intestine. Um, so our protocol, like we always took basically a couple still images, but it was predominantly cine clips. So we would just start in that right lower quadrant, try and locate the ileocecal junction. If it's not visualized, at least just image in the right lower quadrant, couple transverse images, couple sagittal images, and then we do some sweeps. So we do a transverse sweep. So we just label it, right lower quadrant, superior to inferior. And we do a transverse sweep, superior to inferior, right lower quadrant. And then we do right lower quadrant sagittal, and we do lateral to medial. So we just do a transverse sweep, sagittal sweep, lateral to medial, right lower quadrant. And then we move up to right upper quadrant, and we look at the area up here. Same thing, a couple transverse images, couple. So as we were scanning through, looking around, and then we take our representative images. Do transverse right upper quadrant, sagittal right upper quadrant, and then a quick sweep. Transverse, right upper quadrant. So now it's right upper quadrant. RE. Same thing. Lateral, superior to inferior, lateral to medial, and then we move midline. So then we're assessing the large intestine midline. So we do midline upper. So same thing. A couple static images and then a sweep. Superior, inferior, lateral, or right to left, since we're midline. And we move actually to midline lower quadrant. And we move, left lower, left upper, or left upper, left lower. It doesn't really matter, but you just continue. So basically, you're doing 6 quadrants or 6 areas, within the abdomen. Same thing, sweeps, a couple static images, and you're assessing the entirety of that large intestine. Because potentially you just remember, within that large intestine, that small bowel is looping around, it's going all different directions. So you could have a portion of that small bowel push into the large bowel there, cause an intussusception there. The large bowel could also, again, create the intussusception. So again, you could push forward and create the intussusception within the large bowel. So that kind of gets me to my next point that these intussusceptions, they're actually two types. We have large bowel intussusception and then small bowel intussusceptions. Um, so for large bowel, these are going to be greater than 3 centimeters in diameter. That's kind of your magic number. So when you scan them and you see the intussusceptions, you're going to measure and transverse the diameter of it. If it's greater than 3 centimeters, it's most likely a large bowel intussusception. Small bowel are going to be less than 3 centimeters in diameter. So the importance of that is that these small bowel intussusceptions that involve loops of the small bowel, kind of doing that same thing, that telescoping. Um, but these are transient, meaning that they come and they go. So they kind of form. Kids in a lot of pain, that's when they're having those inconsolable crying fits and they're screaming bloody murder. And then they kind of just relax and then do themselves. And it's totally gone. Kid's totally fine. And those are the types, that give the parents fits. They don't know what's going on with this kid because they're losing their minds at one point and then they're smiling and laughing like nothing ever happened. So small bowel intussusceptions, these are called transient. They come and go. Some of the theory behind it is that enlarged lymph nodes might act as like a trigger point or a lynch point to cause these intussusceptions in the small bowel, as well as potentially in the large bowel. So if a kid is sick, they have enlarged abdominal lymph nodes, they can potentially lead to the development of intussusception. With intussusception as well, what was I going to say? Things like strep. So when I'm doing like a patient history, I'll ask, the parents, has your child been sick recently? Have they had a strep infection or anything like that? Strep will cause enlarged abdominal lymph nodes. Any recent sickness that could, potentially be causing this. So with the large bowel intussusceptions, the ones that are over 3 centimeters, these are the ones that are not transient. So they form, they stay there. These are the ones that will lead to that bowel obstruction. And these are the ones that require the surgical intervention or the IR intervention to reduce and get rid of them. So these remain. These are the ones that we're really concerned about. Small bowel intussusceptions, like I said, they're transient, come and go. So you can actually be scanning it, see it, take your pictures. By the time you're done taking your pictures, it's gone. And you can actually maybe do a clip of it, forming and then undoing. So we're talking age range now for kids with intussusception. The kids are young. So usually these ileocolic intussusceptions, the large bowel, with the terminal ileum going into the cecum, are between the ages of 6 months and 2 years. So it's little kids that we're looking at these intussusceptions. I've definitely seen them in some older kids, 3, 4, 5, 6. I think I had a kid who was like, 7 or 8 that's probably around the oldest I've had. And I really felt bad because that kid's going to, remember the procedure that they have to do to reduce them because it's not comfortable at all. So like we were saying, signs and symptoms, these children present what they call it colicky abdominal pain. It's more than colic. They're in tremendous abdominal pain. But it comes in waves, it comes in goes. They also may have vomiting, bloody stools, so they refer it as current jelly. So these dark brown stools. They might be abdominal distension or palpable mass, about 50% of patients. So again, the age of the child, how thin they are too, you could potentially palpate it. With intussusception as well, they'll often get abdominal X-ray, so they can potentially see it on an abdominal X-ray, or at least look at fluid levels within the bowel to potentially see if there's any sort of obstruction with the abdominal X-ray. So that might help you as well. So the exam itself, again, perform patient supine. So this says you're, dividing the abdomen into 4 quadrants. I like to do 6, just to make sure you're thorough, especially getting that midline upper for the transverse colon. Because again, like I said, it could be anywhere along the large intestine where a large bowel intussusception can form. Then I like to include like the midline lower to look at the small bowel. So maybe there's small bowel intussusceptions going on in there. Follow the small bowel as it's looped up. So followed by, focusing on the bowel, use a high frequency linear transducer. The bowel is followed and starting that right lower quadrant as we move throughout the quadrants. So sonographic appearance of intussusception, it's known as a target sign or a donut sign. So we could see the concentric layers of the bowel, the mucosal layers of the bowel as it's telescoped in on itself. So it creates a very distinctive appearance. So, we got first loop of bowel, second loop of bowel, third loop of bowel as kind of like as it's kind of telescoped in on itself. So these concentric rings are resulting from the visualization of additional bowel wall layers within, that intussusception. Another term you might see, on board exams is a pseudo kidney or sandwich sign or sandwich appearance. So this is when you try and turn in long axis on that intussusception. This is just showing some dilated loops of bowel. You got your first loop of bowel, your outer layer, other loop of bowel in between. In there, another loop of bowel. Maybe the third one, or fourth one. So in transverse, that's going to be your intussusception. You're going to measure. And then if you turn in sagittal now, the doctors are also going to want to know the length of it. So stop share. So that's transverse. So get your transverse measurement. You could do. No one's going to fault you if you do another transverse measurement that way as well. But definitely an AP measurement. And then you're going to elongate and turn on it. And that same structure, you're going to have outer bowel. They're going to want to know the length of it as well, how long that intussusception is. So this is the one that creates like a pseudo kidney appearance. I think I got Sag pictures here. Oh, oh. Well, the textbook had a good Sag picture of inception. Actually, I think I have it on D12. Let's see, stop share. And these are some nice inception pictures. So the procedure to get rid of a large bowel intussusception, the first procedure that they're going to do before surgery, because sometimes they do have to go to surgery if they can't reduce this or get rid of it, is they do what's called an air enema. So they bring that child to the interventional radiology suite, and under fluoroscopy, they insert a catheter into the child's rectum, and they start to administer small little puffs of air and fill the patient's large intestine with air. Beginning in the rectum, and they're going to try and push it forward or push it out using air. So it's an air reduction enema. Um, if you imagine the worst gas pains you've ever felt in your entire life. Fortunately, these kids, I hear them screaming. They strap it down from this procedure. So, like I was saying, that one child that was like 7 or 8, he's definitely old enough to remember that, procedure. It's not comfortable at all. But it's better than having to go for surgery to reduce it. So if it's successful, you know, they'll come back to you after the IR procedure to rescan them. And when you're rescanning them, you could see inflammation in that area of the ileocecal junction. So that ileocecal valve might still be inflamed afterwards. So this is kind of what it's showing. So the ultrasound will help differentiate between just inflammation of the ileocecal valve versus there still being an intussusception present. So with this, we're just seeing some inflammation. So we're not seeing those same concentric rings that we did, with the actual target sign. So with hypertrophic pyloric stenosis now. Um, so this condition is when the pyloric channel, which connects the stomach to the duodenum, becomes thickened. It becomes hypertrophic. The muscular wall becomes thickened. Um, and this could lead to obstruction or lead to gastric obstruction. So, whatever's in the stomach is not going to pass into the intestine, into the duodenum. Um, so hypertrophy of the circular muscle of the pylorus is an acquired condition that narrows that pyloric channel. Just kind of a breakdown. So you can see, stop sharing my screen. So we could see distal antrum of the stomach, the actual pyloric channel, the pyloric sphincter muscle, and then the duodenum, the proximal portion of the duodenum. So again, this pyloric sphincter muscle remains shut, and then particularly when the stomach is empty and there's no stomach contents, prevent those gastric juices from just flowing into the duodenum. And then when you eat, it's stimulated to open, and the stomach muscle contracts, it squeezes, and it pushes the food forward into the duodenum, to the intestine for digestion. So this is the muscle that becomes thickened and starts, at that pyloric sphincter and then progresses backwards or more proximal into the pyloric channel towards the antrum of the stomach. In terms of the condition, this is highly uh, related to gender. So again, about 95% of the cases occur, uh, or there's a 4-to-1 ratio, male to female, so 4 times more likely to be in a male infant than a female infant. Uh, and again, the age range is going to be typically, we're thinking that first month of life, so 4 weeks. Um, Again, 95% of cases occurring between 3 and 12 weeks of age. Um, just something to always consider when you're thinking about, pyloric stenosis and age as a child. Be like, oh, this child's like, 3 months old. There's no way it's pyloric stenosis. Um, you don't know if that child was a premature infant. So, their life counter started when they were born premature. So they might have been born a month premature, 2 months premature, in some cases, severe cases. And you don't know. So, really, comparative to a full-term child, they're still within that age range, even though they're technically older. So again, just kind of keep that in consideration. Rarely becomes apparent at birth or as late as 5 months. So, it's not something that typically we see right when they're born. It starts to develop, grows and grows and grows, and then we get the children coming in with the projectile vomiting around 1 month of age. With the projectile vomiting, this is very forceful vomiting, so it's literally can hit you from a couple feet away. It's very strong, forceful vomiting in an otherwise healthy infant. Again, baby's not gaining weight properly. They're dehydrated because things aren't passing through. The mother's milk or formula is not getting into the intestine for absorption. So baby's not growing properly. They're dehydrated. So parent might notice, reduction in diaper changing. They're not urinating as much. In addition to the vomiting. So when we do this exam, ideally, the baby's going to be MPO for a couple hours prior to scanning. So again, depending on your laboratory, so we did MPO 2 to 3 hours. I find out what the boards does, whether it's might be a little bit longer. We want to get them up to the lab, with an empty stomach. It's going to help alleviate some of that gas as well. So we first do the exam, with supine, and then we could potentially do a right lateral decubus, so we turn the baby towards you a little bit. So that's going to help shift that the stomach and the pylorus more towards the patient's right or the infant's right. And maybe we can utilize the liver now as a nice acoustic window to try and see what we need to see. Again, I have to confirm protocol for Nemours, but we would then proceed to feed the baby. We had these little bottles of sterile water that we would give the baby, and then those little sweeties that if you've ever seen, those are like little packets of like almost like sugar water. Put a couple of those into the sterile water just to get the baby to drink that water, because you could trick a baby with a couple of sips. Once they realize it doesn't have any flavor, they're not likely to want to finish drinking the rest of that little bottle. They're like little 1 or 2 ounce bottles of sterile saline or sterile fluid that we'd give the baby. We try and sweeten up just a little bit. Again, if the baby won't drink that, you can see if you can get permission, maybe a little press bill. So basically what we want to do is try and fill that stomach with some sort of contents to then image that contents pass through the pyloric channel into the duodenum. So there's a very specific, image or signal clips that we want to obtain to rule out hypertrophic pyloric stenosis in addition to measurements. Like I was saying, we do a preliminary survey of the abdomen is performed. So we want to exclude other things like adrenal hemorrhage or renal abnormalities, which also have increased incidences with patients who have hypertrophic pyloric stenosis. Look for hydronephrosis secondary to any sort of uretropelvic junction obstructions. Might do a duplex of the kidneys. In addition to that, we also want to rule out a condition called midgut volvulus or midgut malrotation. Oh, I'm spelling that. Midgut volvulus. Definitely butchering the spelling. So basically, that's a malrotation of the gut. So the intestines are essentially twisted. Um, and to rule out midgut volvulus or malrotation of the gut, we look for the orientation of the SMA and the SMV. So when we're transverse, so we got our abdomen, we look for SMV and the orientation of the SMA and transverse. So normally SMA and SMV, if you don't ever remember, I'm stop share. So SMV. Right. So SMV should be to the right and SMA to the left. So same like your aorta and IVC. So IVC is on the patient right, aorta is on the patient left. So same holds true when we're going to talk about the orientation. So this is normal orientation for those vessels. With midgut volvulus or malrotation of the gut, midgut malrotation, the intestines are actually twisted and it causes that orientation to reverse. So instead of the SMA being to the left of the SMV, the SMA is over right now. So you can see it over there now. That's one of the things that they look for. This will create what's called a vascular swirl. So I turn on that, like these vessels now are twisted, so that's in transverse. But in sagittal, right along that, you could see the vessels actually kind of doing a swirl. So get the vessels swirling, and then so you get this swirl of vessels. When you put color on it, you see like what's called a vascular swirl. It's another way you can make that diagnosis for midgut malrotation. So normal pylorus. So this is a nice, beautiful picture here for a normal pylorus. So you can see the little kind of like echogenic bubbles within it. So you got your distal antrum over here, your pyloric channel, and then your duodenum. So duodenum almost makes like, to me, it almost looks like either a mushroom cap or like a snake head almost. It creates like this triangle, this V that kind of sits over the uh, the pyloric channel. So the pyloric channel or the sphincter is just this little part right before that triangle. And that's the part that thickens and grows backwards towards the distal antrum. So again, this will open up, allow for food to kind of pass through. You can really see it almost open like a mouth as the food stomach contents passes through. So you're going to sit over this area. So this is your money shot. This is what you're trying to assess and evaluate. So you kind of stay over this area. You're watching in real time, and you're watching to see as it gradually opens, stuff passes through, and then closes back down. And you want to capture that on simulated clip. If it's normal, we never took measurements, diameter measurements or anything like that. I have to go check those. more is what exactly what they do. But if it's a normal pylorus, there's no thickening and everything's passing through, and you got your clips, signal clips showing it pass through, you're good. When they're positive, it's obvious. They're big, or it becomes much larger. Um, with hypertrophic pyloric stenosis too, when it becomes thickened like that, it's heavy. So I've had ones that kind of really just dive down or dip down posteriorly. Um, and when we're looking at it, there are two measurements that you're going to want to obtain. You're going to want to measure channel length and then thickness. When you're measuring the thickness, you're only measuring this hypoechoic muscular layer. So don't measure this anechoic part. Don't measure any echogenic. You're just measuring the hypoechoic muscular layer. So I would actually take that measurement in the anterior one a little bit, just a hair, honestly. That one's pretty good. So that posterior one I think is too far down. Just again, you're just measuring the hypoechoic area and then channel length. So here they just did a straight cursor. If you have an open trace, you get a better channel length. In terms of positive, I just remember pi, 3.14, if you ever wanted. So 3 represents the thickness. So thickness greater than 3 millimeters. Greater than 3 millimeters. And then channel length greater than 1.4 centimeters. So that's what we use, like our guidelines. So this definitely meets that criteria. It doesn't tell me the thickness here, but that's definitely thickened and that channel length very long. So here they had a channel length 1.8. These criteria, thickness, they got 0.5, so 5 millimeters. Just some pitfalls for when we're doing this exam. There's no fluid, nothing in the stomach. The pylorus isn't going to want to open. So again, it's a response to having something in the stomach that causes that pyloric sphincter to relax, to open, and allow for things to pass through. Another thing too, if you, again, these babies are crying, they're going to get gassed out. You might not be able to see what you want to see and visualize the pyloric channel, where it connects to the duodenum. And the stomach's baby was full when they got there. So that they've been NPO, but the stomach's still full. They've eaten a little bit in your lab, and the stomach, still full through the entirety of your exam. You can document that the stomach, didn't empty during the course of the exam. It was full when they got there. It's full throughout the duration of your exam when you're trying to image. So that could also potentially indicate there's some issue going on. So these were actually some normal ones. Then if the stomach's overly distended, sometimes this could displace it posteriorly, make it very hard to delineate. This is one that was likely positive now.
Sorry, I can't see anything besides the whiteboard. Oh, never mind. Now you're doing it.
So these were just some normal pylori studies. Again, when it's positive, it becomes heavy, so it can be displaced posteriorly, making that length a little bit harder to image. Here was a transverse, so turning transverse on that, you could see the thickening of that channel. Uh, so in terms of imaging techniques, if there's adequate amounts of fluid within the stomach, then longitudinal images of that pyloric muscle are obtained, placing the transducer transversely across the right upper quadrant, just below the level of the xiphoid process. So kind of think like, kind of left lobe liver. Think you're going left lobe liver transverse. So you're maybe a little bit more midline, but if you turn them, it's going to shift everything towards the patient, right? I've come low sometimes and even use that liver scan upwards to image. So you might have to kind of just think out of the box a little bit, maybe come a little bit high and try to down. So you try to utilize multiple windows. Transverse short axis images of pyloric muscle are often obtained from the right coronal plane when the pylorus is abnormal. Gallbladder is initially identified, after which the transducers angle medially until the hypertrophied pylorus muscle is noted. That was one trick that you can try and do, try and find gallbladder and transverse and then angle a little bit more medially. They're usually right kind of around that same level. So again, we want to try if there's not enough residual gastric fluid present, we're going to administer some glucose water in a bottle or syringe. We could potentially use Pedialyte or sometimes breast milk. Will have a similar appearance. So Pedialyte will have a similar appearance to water as well. However, formula is more echogenic. Might occlude a good view. So we can try supine. We could try decuing them. Again, that might help you as well. Allow for maximum visualization of the stomach and pyloric canal. This is most advantageous for documenting that transit of gastric contents into the blood. So textbook here gives you some, again, like I was saying, measurements. So muscle thickness greater than 3 millimeters and a length greater than 15 to 16 millimeters. I made it easy, like where we just made it easy on ourselves, like on back in New York, we just memorized pi for channel length. So 1 millimeter longer isn't really that much difference. But textbook says 15 to 16 millimeters in length. And muscle thickness is the most diagnostic measurement. So, like I said, channel length can be kind of hard or a little more difficult or challenging to image, particularly if it's curved and angled more posteriorly. If you're not using, an open trace to trace it properly, so you can be slightly off, but really rely on thickness. The thickness is what the issue is. And that thickness eventually closes it off and again prevents things from happening. That's kind of a good little kind of caveat I want to mention. I did one study, it was thickened, but there was still a little bit of stomach contents getting through that channel. And the radiologist that was on, the resident, read that as normal. I came in the next day, the pediatric attending sat me down and they're like, "What'd you think of that pyloric study you did last night?" I was like, "That was thick." And they're like, yeah, thank you. So that resident got reamed out. And I felt bad. But yeah, it was thickened. It was obviously positive because it wasn't a normal looking, pylorus by any stretch. I mean, even though some contents was getting through, come back in a couple more days, it's probably gonna be completely sealed off and nothing getting through. So again, go off of thickness. Again, you might be couching it in the early stages. So if the muscle is thickened and elongated, the mucosal extends to the antrum. This appearance has been called the cervix sign. It does kind of look like a cervix. I agree with that. So again, we're measuring just that hypoechoic muscle to its junction with the echogenic central canal. Pyloric channel length is measured from the proximal to the distal extremities of the echogenic central canal. So you could see actually again that kind of like that the mushroom top or that triangle for the duodenum. So you could see there is the duodenum and the pyloric channel itself, and then that's the actual sphincter and the muscle that then grew and become thickened in hypertrophy. Transverse views allow for measurement of the pylorus overall, the wall thickening. So sometimes it's referred to as a bagel or donut appearance of a hypertrophy pyloric muscle. Sometimes, in these infants, we can actually see reflux. So we can see some of that, gastric context going in the wrong direction. Or even in normal cases too. Um, I've had instances, normal pyloric study, but they just have reflux and that reverse peristalsis coming back through the pyloric channel into the stomach. Um, One consideration too is something called pyloric spasm or pylorospasm. So this is a muscle. The muscles can spasm. So when they spasm, it's thickened. So think of like, you're flexing your muscle, it's tight. When it spasms, like, oh my God, I got a cramp, it's a spasm. So that muscle can become thickened as a result of a spasm. So with the pyloric study, we have to image it for a certain amount of time. So we had, let's say 15 to 20 minutes, we had to actually be over the pyloric channel, imaging it, taking several clips of it as the stomach contents is passing through, staying over it, ensuring that, it doesn't spasm. Because that can happen. We can wind up with a temporary spasm and it relaxes down. It's okay. But with those spasms, typically the muscle is within normal limits as well. We talked about midgut malrotation. Some other surgical conditions, again, we might encounter. There might be mesenteric or mental cysts that you might encounter. Duplication cysts within the bowel. Duodenal atresia, so duodenal is underformed, underdeveloped. And then, if this baby was born and they ingested meconium while in utero, we might worry about meconium peritonitis. Another potential, surgical condition is or not surgical, but another emergent condition is necrotizing enterocolitis. So necrotizing enterocolitis is a very serious condition. that also has with it a high morbidity and mortality rates. So with this, the bowel is undergoing necrosis and now must be surgically removed. This results in a condition called short bowel syndrome. We're planning abdominal radiography is the imaging modality of choice, but so they're going to go for an abdominal like angiography or radiography. So it's abdominal like fluoroscopy. So abdominal contrast and abdominal X-ray. Ultrasound, we can depict intra-abdominal fluid, potential abscess formation. So there's going to be little gas bubbles that we see within the walls of the bowel. We might see some distension. Here we go, some necrotizing enterocolitis. So if we do, want to suspect or we're suspecting it, we see, the walls of the bowel, they appear thickened. We got some echogenic gas bubbles within it. And then this posterior dirty shadowing as a result of that gas bubbles. So the bacterial, necrosis. Another area here, the echogenic gas bubbles, some dirty shadowing. Um, so any questions about aortic stenosis, intussusception, appendicitis? I have some good pictures I actually posted on D2L. So, take a look at some of the pathology images that are on there on some of the files. It's just stuff that you have to just kind of train yourselves or train your eyes, getting used to seeing. Like I said, intussusception, you're not going to miss. Appendicitis, when you get comfortable scanning them and knowing what you're looking for, they're not so bad. And then probably the most challenging one is the pyloric stenosis studies, just because those babies get so gassy and they're fussy and parents are all upset and worried. It's stressful. There have definitely been times I've been in there like 30 minutes, 45 minutes, almost an hour, like trying to get a couple images for this pyloric channel. And just, oh God. So if the baby can calm down, relax a little bit, and let the mother hold them, try and relax them, and then you try and scan, give the kid some breaks, might help a little bit. That's probably one of the more challenging ones out of the three. Some of the ones that I shared. I was just checking what I had on here.
To let you know for next week, I'm gonna be watching the recording of the Zoom because I have drill Friday, Saturday, and Sunday.
With that, people, have a good weekend. Be in touch with all of you.
Thanks, Dan.
Great.
Thank
Thank
you.
you. Bye. Have a good weekend.